your vulva, your urethra, your bladder, your vagina are rich in hormone receptors. When you take birth control pills, it's going to change the health and the microbiome of your tissue.
Hi, welcome back to the channel. My name's Melissa, and today at Live UTI Free, we're talking about UTI and hormones. We have another amazing guest, Dr. Rubin, and in our conversation, we're going to cover things like estrogen therapy, contraceptives, and hormone replacement therapy at any stage of life. I also wanted to mention that we have many other resources for patients experiencing recurrent and chronic UTI, and we've linked to some of those in the video description below. Lastly, if you enjoyed these videos, think they're important, and want to support what we do, make sure you click subscribe and tick the bell so you'll be notified of videos when we post them. And other than that, thanks again for joining us on this journey to making change in women's health. I would love to jump into some of the premenopausal hormone support and then contraception, because we did get a bunch of questions about that. The first was about the bladder lining and whether it changes during the menstrual cycle.
I don't know if we have that data, but I would absolutely love that data. And I don't know exactly how you would easily study it. It would probably force a lot of women to get cystoscopies and bladder biopsies, which would probably hurt them. And so it might be difficult to get done. But I have actually really wanted to do a study of cystoscopic changes, like what it looks like of bladders between premenopause, postmenopause, and can you spot, because I can spot a vulva that's hormonally healthy. Can you do the same with a bladder? And I don't know that we know that answer.
Yeah, so many people in our community do report that their UTI symptoms change with their cycle and can't get a very good explanation of that. Do you have something to offer there?
Getting the right hormone status and figuring out what the best thing is. And I in my practice, I play, like when you have data, great, but sometimes you have to play around with it. And I say, what is the worst thing that could happen here? What are we fearing? What can we tinker with? Especially in perimenopause, we see a lot of hormones change. Even though you're getting periods, the testosterone rate might be dropping. And so I think testosterone is something that needs to be played with a little bit more in this space. I think estrogen is something, progesterone. I think, and the problem is no one wants to study it because of the fluctuations and the complexity. Whereas I say, well, why not play around and see what works, and I don't think I'm going to harm someone. And so I think there is definite truth to this, but we have a lot of work to do.
There was a few questions from people who have had partial hysterectomies where their ovaries remain. They wanted to know if they would still experience a normal cycle minus the menstrual bleeding, and if that could then still impact their bladder.
Absolutely. If they felt that their hormonal fluctuations affected their bladder. And the question is when I spend a lot of time just looking at the picture of the menstrual cycle with patients, and we look at it together. Again, birth control changes everything. So it's going to change, the hormone level. So you can't look at it as for you if you're on birth control. But for people who ovulate, looking at that picture and figuring out, okay, when are my symptoms the worst? Is it when your progesterone is high? Is it when your estrogen is dropping? Is it when your progesterone is dropping? Is it we look at it and it's not like a perfect picture. It's not a perfect situation, but it gives us this idea of, can we play in this space? Can we add some progesterone? Can we add some estrogen? Like, where can we supplement to see if you feel better? And then we don't know, what is the optimal dose? What is the right timing? I have patients who say, gosh, when I was pregnant, I felt great. Or when I was pregnant, I felt horrible. And that gives us a sense of, well, I don't know that I can get your estrogen back to 3,000, but is there room to play with this?
So when someone still has a menstrual cycle but might need hormonal support because they are experiencing symptoms at certain times, do you only provide that support at those times, or will they need to be on something?
Depends on the patient. Depends on the patient and the situation. And again, in the discussion of here's what we know, here's what we don't know, what could we try? So for me, I like to try and play around with FDA approved hormones as opposed to birth control pills. Of course, if you need, because I see, a lot of the other side effects, a lot of women don't like birth control pills for the other side effects. And so we see if we can play around with progesterone or estradiol and that sort of thing. So it's
Okay.
again, there's a lot of it's not a one size fits all. And someone who has PMDD or PCOS is different than someone who is a runner who doesn't menstruate because they're such an amazing athlete, and they also have like no hormones in their body. So you have to find the right thing for the person.
You just mentioned PMDD, which was one of the questions. What is the difference between PMS and PMDD, and are there symptoms that could help someone differentiate?
Oof, that's a gynecology question. I don't know the definitions, the difference in the definitions. I think there are specific difference in definitions. I just know I work with patients in looking at that menstrual cycle and saying, okay, when do you feel awful? Let's look at it. What days do you feel awful? I don't know if it's because your body hates progesterone or your body hates when progesterone's dropping, or it could be that your body hates that your estrogen is dropping. And so can we help minimize that dropping, or can we tinker with the system a little bit? It's not a perfect, again, when people are doing research and creating medications and drugs, they need big picture things. They need this works for everybody. They lump everybody together, and that becomes really challenging in these types of situations.
How accurate are tests for reproductive hormones? That people will often have one snapshot test during the cycle and be told they're fine. How do you pick what is going wrong throughout that whole cycle?
I don't know if anyone has watched the Hulu documentary about Theranos, where the lady got in trouble because she was trying to, she scammed everybody, and it was a big controversial thing. But the reason I bring it up is I wish that the technology was there for us to put your finger on a little button, and then every day we could kind of see what's going on and do all these tests and monitor. And maybe that's the future, right? Maybe it was just a little too soon, but maybe that's the future. There's so much, in this space, testing has gone light years ahead of where we are in our understanding of what the testing means. And that frustrates the crap out of patients, as it should. And so all of these saliva tests and these like very expensive things give you numbers and give you all these cool things that tell you all of these things. But when you look at the research and the data and what's published, well, you don't see saliva tests on there, and you don't see, you just don't see it. And so could saliva testing for hormones one day be accurate and be the gold standard? Absolutely. I'm not saying they can't be, but these companies should then do the work to then actually publish data to say, oh my God, look how accurate this is. This should be the gold standard. But they don't, because they'd rather take your money and run with it, because they don't need to do that, because you're going to pay them regardless of whether it's real or not real. And that is why I cringe and I get so frustrated. I get tomatoes thrown at me, and I'm sure your people will be so mad at me by saying these things, but that's the truth. And so we have to demand better science, better evidence, and we must demand that it gets done, because these companies are taking advantage of women in this space at very large levels.
So in the meantime, how do you identify where the problem is in someone's cycle?
Yeah, so it's a lot of the story, and I do like snapshots. But I understand that I do blood testing through people's insurance, but I do blood testing, and it is a snapshot. Is it the full story? Is it the full picture? I have a patient right now who feels awful at a certain time of month, and so we actually got 3 snapshots where we got her tests, at the baseline at day 2 to 3, where her hormones are the lowest. We got some testing at ovulation, and we got some testing in the luteal phase, and it's not perfect, right? And she understands that this is a snapshot, and we're being detectives. That means we may go down the wrong road, and we may have to walk backwards, and we may have to go down another road. And so I am not of the mind of like, again, your body, your choice, of like, no testing ever for anyone. You don't need it. I think, again, it's not a one size fits all approach, right? What's right for one patient is not necessarily what's correct with a different patient. I also think patients like baselines, and they like to look at the change. So if you're in menopause and you see that your estrogen is 0, and then we start you on a patch, and then you see that your estrogen is now 50 and you're feeling better and like you're doing fine and your hot flashes are gone. Yeah, technically you didn't need to see it go from 0 to 50, but patients that is a very valuable visual for patients to actually see the change. Similar to vaginal pH, I have a little pH paper in my office, and they see the pH go from 7.5 to 4.5, and they see that their hard work is paying off, and they actually see the change. So they're going to use their vaginal hormones twice a week forever. And so I do that in my practice. It's not necessarily the gold standard of care, and so this is where we push the gold standard farther, and we research it, and we publish it, and we keep moving it forward, and we question the standard. We question it. It's great to question things and to prod and to poke and disrupt, but we have to also hold everybody accountable for doing the work.
Do you think it's worth patients monitoring their vaginal pH with strips like that?
I don't want people to go crazy and test it every day, but I do think if you're on vaginal hormones and you're still getting UTIs, sure, put a pH paper in there. And if it's not acidic, well, your vaginal hormone's not working, or there's something going on, and maybe we need to change the modality. I think it's super helpful. I have patients who use a hormone therapy on their skin, and they're like, man, I don't feel any better. Like, I'm using this high dose hormone therapy. You check their levels, their estrogen's still 0. Well, ma'am, you're using a fancy hormone lotion that's charging you a lot of money, but it's not actually absorbing into your skin and making any difference. And that's where I think the numbers and the pH and things like that can be very helpful.
Okay. You mentioned contraception and how people aren't afraid to take that, but a lot of people in our community report that it is when their UTI started, that they got an IUD or that they started on a contraception. Do you see that in your own practice a lot?
Yeah, again, when you play with hormones, there are consequences, sometimes good, sometimes bad. And so there are risks to everything. Good Lord, there are risks to supplements. One of the number one reasons of liver failure right now are people taking too many supplements, and their liver just goes nuts because it doesn't know how to process all of it. And so there are risks to everything that we do. And hormones of any kind, in any way, there are going to be benefits and there are going to be risks. And so, yes, hormones can change remember, your vulva, your urethra, your bladder, your vagina are rich in hormone receptors. When you take birth control pills, it's going to change, your ovaries are no longer going to produce their own hormones, and any testosterone that you do produce is going to get gobbled up by a protein called sex hormone binding globulin, which decreases how much testosterone you have circulating, which is going to affect the health and the microbiome of your tissue. And so IUDs don't tend to do that as much, but that doesn't mean they can't cause any problems ever. Remember, you just asked about progesterone. I said, we don't know. There's definitely, I certainly have patients with hormonal IUDs who say my vagina is so dry now. It's rare, but I do see people complaining of it. I've seen patients with things and bacteria on the string of the IUD that we take the IUD out and their infections get better. There is so much we don't know, right? And it really is not a one size fits all. I love IUDs. That doesn't mean that IUDs don't have complications, right? And so I think that the vilifying birth control and the vilifying IUDs is not the correct answer either. We must demand more birth control options, more vasectomies for our male patients, more reversible non-hormonal birth control options. And we must, birth control hasn't evolved in its research in decades because we're not forcing the scientists to do that. And so we have so much work to do. And I just don't know how to start there's so much to do that it's sometimes hard to get out of bed in the morning because you're like, where do we start, right? Because unless you have one issue that you're working on, it gets very watered down.
Yeah, I'm familiar with that feeling. There was another question about DIM as a supplement and what that is and whether it might be beneficial for UTI.
I have absolutely no idea. And so when it comes to supplements, my take is always this. At least in the United States, there's absolutely no oversight into the supplement industry. So we can argue and debate supplements as much as you want, but at the end of the day, I don't even know that DIM, whatever that is even in the bottle, right? Yeah. So if you present me a study on DIM that shows it's the greatest thing ever to prevent UTI, well, what company do I get it from? Which bottle do I use? How do I know that it's actually in there? So I can't even start a conversation about supplements because until someone gives me some assurance that what's in it is actually what's in it, and that you have studies to show that it's actually helpful. And so that's where I get very frustrated. So in the UTI space, listen, I don't have anything new to present, right? We know D-mannose might be helpful. We know cranberry might be helpful. We know my biggest problem with the AUA guidelines on UTI is that they give you all these options, and then the last one they're like, and you should use vaginal estrogen. And I was like, guys, come on, you got it wrong. It should be everyone uses vaginal estrogen, and then you can sprinkle in these other things which might help. They sort of made them all seem like they were equal in benefit, whereas we have like so much data on vaginal hormones, which is why I've lobbied the Urology Association to do a guideline specifically on genitourinary syndrome of menopause, so that we can just like say it loud and clear of like, urologists should be treating patients with any urinary symptoms with vaginal hormones, period, end of the sentence. And it forces, if you have guidelines, it's going to force insurance companies to pay attention, God willing. It's going to force the urologist to say, this is our space. We should be doing this. We can't just expect our gynecology colleagues to deal with vaginas. We also have to talk to women. So this is the mountain that I live on.
Well, I hope you're successful, because those guidelines do make a huge difference. A lot of patients say that doctors can't help them because there aren't guidelines that can guide them. So, but
there are, I will say, in the UTI guidelines, it very specifically says it, and I believe it's number 18 on the guidelines. It says, if you are this is a really important sentence. If you are peri or postmenopausal woman with UTIs, vaginal estrogen will prevent UTIs. And so I've seen a lot of patients online who say, my doctor will not give me vaginal hormones because I still get periods. And that sentence, you can bring that sentence into the doctor and say, see, this is why you should give me vaginal hormones. And you should follow Dr. Rubin on Instagram or Twitter, because she knows, because she's not afraid to do it. So this is the prescription you should give me.
Yeah, that's really good advice. There was one more question about supplements, which was around vaginal probiotics and whether you think they might be helpful.
The only probiotic on earth that is proven to fix your microbiome and make it perfect is vaginal hormones. Vaginal estrogen, or DHEA, will make your pH 4.5, will reproduce your lactobacilli. It will take 2 to 3 months, and it will only keep working if you keep using it. There is no probiotic that is on the market that has any proof that it does anything to the level of vaginal hormones. And so yes, the idea of maximizing our microbiome, the idea of a vaccine or a supplement or something that fixes everything, but we have something. It's been around since the 70s. It works amazing. There are many different types, and yet no one's using it. And I can't figure out, it's because it's the fear of the word hormone, which is so strange because no one fears it when it's birth control for reproductive rights. Nobody fears hormones when they're young and taking birth control. They may have side effects. They may not agree with them, but they don't fear it. And yet as soon as you turn 50, the word hormones all of a sudden make you terrified. I had a patient with, I think I'm doing a lichen sclerosis podcast in a few minutes, but I had a patient who had lichen sclerosis, and I was on the phone with her, and she said, oh, she has horrible lichen sclerosis. She has pain, she has itching, she is miserable. They started her on a very, very heavy medication. I said, well, I see you have vaginal estrogen on your med list. Do you take it? Oh, no, I can't take that. It causes cancer. And I said, oh my God, lady, your out of control lichen sclerosis actually causes vulvar cancer. Like, this actually causes cancer. Vaginal hormones have never caused anyone cancer. And so that's the fear. That's what we're working with, is she had the correct prescription and still she wouldn't use it. And so we have so much work to do, and you're doing such important work, Melissa, because we have to just educate women to understand it, because unless they understand it, they won't put it in their vaginas. They won't use it. They'll buy some supplement on the internet that has no research behind it because it feels safer, but it is not safer.
I have 2 quick questions about UTIs after sex before we have to wrap up. The first one is, for UTIs triggered after sex, do you think it's usually a reinfection, or could it be caused by a persistent infection that's just been flared up?
Okay, I have a very controversial take on this, and you are I'm going to get a lot of tomatoes thrown at me. I don't think right at sex, if you are having pain right at sex, and sex is painful or sex is painful after, and you say, oh my gosh, I got a UTI, I don't think bacteria work that fast, in my opinion. And I think more often than not, remember that opening to the vulva is bladder tissue. It's called the vulvar vestibule. very hormone sensitive. When anything rubs against it, like a penis or anything else that might be inserted, right? It is raw, it is irritated, and it does not like to be touched. That's bladder tissue. The vulvar vestibule at the opening of the vulva is bladder tissue. So when it's irritated like a rug burn, guess what your symptoms are going to be? Frequency, urgency, dysuria, and pain. It's an inflammatory thing, not an infectious thing. Your body is, if it hurts, we are trained to think this is an infection. Oh my God, I got a UTI. But it doesn't work that fast, right? Now, if you're the person who a couple of days later starts to have burning and pain, I'm not saying, an urgency, yeah, get a dip, get tested, get a culture. I think this idea that a penis goes in and bacteria now are there and are causing this acute infection, and I need to take, what happens is then women take antibiotics, then they start to feel better. But what makes them feel better is that they're now not having anything rub against they're not having sex, so they're not having anything rub against that bladder tissue, and they get better on its own. Think about rubbing an open wound. It hurts, right? It's really irritating. You would never take an open bladder and just like rub against it. That would irritate a bladder, but you essentially have bladder tissue right at the opening of your vulva. That's why it's important to keep it strong and healthy with like a hormonal approach, so that it doesn't hurt to the touch. So it doesn't feel like raw, spicy chili peppers, when anything touches it. Does that make sense?
It does. There are a lot of people that do report it happening 48 to 72 hours later.
And those people, those are that's different, right? That's totally different. My issue is with the people who say, as soon as I have sex, I get a UTI. Yeah. I think too often that's an inflammatory irritant as opposed to an infection. There are no question that there's a whole world of embedded UTI potential or UTI, chronic UTIs that we don't quite understand, and that we have a lot of work to do.
And for those people that do get the infection later, there was one more question, which is it possible that the microbiome of one partner could be incompatible with the microbiome of another?
Sure, anything's possible. I'll never say no to it, right? I have seen things like that happen, and certainly weird allergic reactions and all. It's just, again, our testing is sometimes beyond our ability to know what the heck to do about it. And so things I love you could try. Female condoms, I think, are totally underused. There are these cool things that they kind of attach to the sides of the vagina, and the penis can go in and out. And so it's going to kind of protect the walls. It's not going to be as irritated against. And if semen bothers you, then it won't hit the tissue. And so you can see, is it, am I allergic to my partner? Or, is this an inflamed, I don't know, just like that's why I like being a detective. I said, did you try this? Did you try that? Should we test this? And it takes really getting to know someone and getting to know their intimate history in order to understand, what's happening and what could be happening.
Thanks so much for watching. I hope you enjoyed the video. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com. We have some really important articles related to this topic. For instance, we have one on UTI and menopause, and one on UTI during pregnancy. We'll also drop those links in the description below. Of course, if you like what we're doing, be sure to hit subscribe and tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.